Hi everyone, my name is Ashley Avila-Dawson, and today I'm presenting my signature assignment on pneumothoraxes. So this is just a quick outline of the presentation. We're going to talk about etiology, demographics, anatomy, physiology and symptoms, and then of course diagnosis and treatment and aid. Okay, so first up is etiology. And then this is the types of pneumothoraxes right here. So pneumothorax is a condition in which free air enters the pleural space, causing intrapleural pressure. There's two main categories: traumatic, which is caused by a blunt or penetrating trauma, and then there's atraumatic, which is either primary or spontaneous or secondary spontaneous. Primary means it just kind of happened for no reason and there was no pre-existing lung condition. Secondary is caused by a pre-existing lung condition usually associated, and there's hyperinflation, blockages with those obstructive lung diseases, and it causes the tissue usually to rupture and leak. And then also they can be classified as simple, tension, open, or closed. So moving forward, the second part of etiology is risk factor. And the main ones I just want to point out are the differences. So in primary, it really has to do mainly with genetics and a little bit of behavior. So mainly smoking with behavior. And then genetically, it's really only majorly seen in tall, thin males who are especially smokers. And then there's a syndrome related to that tall, thin male structure, which is called Marfan syndrome. It's a genetic condition. And then in spontaneous, the main obstructive lung diseases that cause this are COPD first and foremost, more than any of them, and then asthma, and then cystic fibrosis. The other two are a little less common. And then traumatic is just blunt or penetrating objects, usually car accident, gunshot wound, stabbing, that kind of thing. Moving on to demographics. There's a lot of great information on this demographic slide, but for the sake of time, the main things I want to point out are this mainly occurs in males in both primary and spontaneous, way higher rates than women. And then for primary, this happens in young people, 20 to 30 years old, and mainly males, like I said. And then secondary spontaneous mainly happens in older people, and it's a result of those like lung disease, like we talked about. So that's the main thing I want to point out here. So this chart I found is really good in an epidemiological study done. And most notably in 2015, there was around 265,588 cases of pneumothorax, which was tracked through outpatient, inpatient, ED visits. And then going down, we can see that obviously traumatic pneumothorax happens more often, and so does primary spontaneous. So secondary is the least common. And that's for the ones that were classified and such. Okay, last slide. I don't have a ton of time to talk here, but main thing I want to point out is that smoking. The risk for spontaneous pneumothorax is 102 times greater in heavy smokers versus non-heavy smokers. And then also for traumatic injury, 72.3% come from rib fractures. And then lastly, for COPD, 26 out of 100,000 patients are going to get pneumothorax if they have COPD. So it's important that we look at the anatomy of the lungs, especially their pleura, when we're trying to understand how pneumothoraxes occur. So we have two different layers of pleura in our lungs, or serous membranes, which are made from mesothelium, a simple squamous epithelial tissue, and then also areolar connective tissue. So there's a parietal pleural layer, which connects or clings to the thoracic cavity wall, and then there's a visceral pleural layer, which clings to the actual lung tissue itself. The viscera and the parietal meet at the hilum of each lung, and then there's a space or a potential space that contains serous fluid. Um, it's important to note that the pleural space is only potential space when the lungs are fully inflated, because then no space actually exists. The serous fluid is also very important. It's produced by the serous membranes, and its goal is to provide like an oily, lubricating substance that decreases friction and also contributes to maintaining the pressure in the serous membranes, which is important. The tension allows the viscera to be pulled with the parietal during inhalation, so they're not separating. Okay, moving forward. We're just going to stop here real quickly. And this is just two great pictures showing one, the capillary and alveoli connection here on the right. And then the left is I want to talk about normal alveoli function. So oxygen will be coming in and able to diffuse into the blood while carbon dioxide is flowing from pulmonary capillaries to the alveoli to be exhaled. There's a gradient established here where oxygen is in high concentration in the alveoli and then in low in the pulmonary capillaries, causing the flow to be towards the capillaries. That's like the main thing here, because that's also going to get disrupted. So next is physiology and symptoms. And on the left here is a great picture of just like a general pneumothorax, what it looks like. Okay, so this slide's pretty beefy, but there's just a couple things we really need to understand. So first, there's three different types of pressure when we're talking about ventilation. There's intrapulmonary, which is right here inside the lungs, or in the alveoli really. And then there's intrapleural pressure, which is in that potential space cavity we're talking about. And then there's atmospheric pressure. So intrapulmonary pressure, the ones in the alveoli, is always greater than the interpleural pressure in that space. So the lungs are able to move against the low pressure when they're expanding and not have to work so hard. And then as we previously learned, things like air like to follow concentration gradients, so moving from areas of high pressure to low pressure. So what happens when there's a leakage or a break, like right here? Like what happens when air starts accumulating in the pleural space? Remember we said there was no air ever there before. So the gases that are contained in atmospheric air, like oxygen and nitrogen, have the ability to generate kinetic energy. And they're going to start increasing the pleural or the pressure in the pleural cavity, which was once a negative pressure or below intrapulmonary. So now it might be positive compared to that intrapulmonary pressure. And now the normal ability of the lungs to move or inflate against the pressure gradient is lost because now they're trying to push up against all this pressure in here, in this area right here, and they can't. So this pressure in the pleural cavity is going to accumulate and it's just going to keep pushing on the lungs this way. And when it does that, it causes them to collapse. And a collapsed lung is going to exert pressure on the alveoli of the lung, causing even the alveoli structures to collapse. And now oxygen is going to be struggling to get through the collapsed alveoli, which is going to affect the whole gradient we just talked about, causing less oxygen to move into the blood. And then these are kind of just like the general sequences of events that can occur in any of these pneumothoraxes. And then here we can see just a couple different types: the open, the tension, and the closed. Okay, so with all that pressure increasing in that space and the collapsed lung, it's going to create chest pain, dyspnea, which is like short labored breathing, and tachycardia is kind of like, it's mainly dyspnea and chest pain. And that chest pain can even radiate into the shoulder of the same side of the collapsed lung. And like we said, tachycardia, increased heart rate, or low blood pressure, the vascular system is going to be compromised too in this kind of situation. And then here we have the long-term outcome and is reoccurrence basically. So about 50% of the cases of pneumothorax, a person will experience another one in about 50% of those cases. And there's no really like bad long-term outcomes. It's just you could get another one essentially. And if there's successful intervention, you should be just fine after. Diagnosis and treatment. Let's see. So for diagnosis, it's going to be a chest x-ray. And then, like I mentioned just a second ago, osculation is just testing the breathing sound. So that's a little bit, that's going to probably be like the first step with patient history, right? And then a chest x-ray would be next. And this is one where you can see actually a collapsed lung. So how it looks is a little bit different. And then AI technology actually, I read a study they did used 1,000 different scans and they were just using like commercial AI tech. And they had success in the study, so it could be utilized to help radiologists detect pneumothoraxes more efficiently or to help them improve outcomes. And then also different methods like CT or chest radiography can be used as well. And then treatment, it will vary for pneumothoraxes depending on how it happened and the extent of the trauma. If there's an open chest wound or more critical conditions stemming from the traumatic injury, that's obviously going to have other treatments that take place. Usually in these cases, a chest tube is put in place. Also, depending on the severity of the pneumothorax, patients could be sent home with minor intervention because less severe cases usually can heal on their own and don't need these types of treatment. However, a tension pneumothorax requires immediate needle decompression, which I used to see this all the time in Grey's Anatomy when I watched that show. It just involves inserting like a large bore needle into the second intercostal space at the mid-clavicular line. And after this is done, there should be like this release of air as the tension comes out and from the air. And the patient should improve relatively quickly. And then that's it. These are my references. Thank you, guys.